All right, so does every table have a reporter ready? So I can go in any order. Should we start here with the illustrious table 7? So we have these 3 prompts, but if there's other things that emerge that you want to add, please do feel free. And then we'll have some time for non-reporters to weigh in as well.
So our table talked almost the whole time about, and so we converged on the idea that over-specialization was sort of the theme, and it was something that here in the United States in the medical care system was a problem, but it also was a problem in low and middle income settings. And so even in addition to providing medical care, there's also disease-specific community advocacy for HIV, but not for other diseases, or not for better primary care, and disease-specific supply chain logistics for getting the antiretrovirals to the place where they need to be on time, but there's absolutely no attention paid to other basic medicines. So that was what we converged on. A new idea that hadn't come up yet in the workshop, well, actually, Sylvester pointed out that one of the indicators of a country's improvement in medical care, providing better medical care, tended to be the number of specialists that were trained. And, you know, he noted that Kenya would compare themselves to Uganda by the number of cardiologists that they had in country, and that contributed to this whole problem that maybe they'd borrowed from the Western world inadvertently, but maybe had a negative consequence. So that hadn't come up in our discussions at this workshop previously. So we actually are overachievers, and we have 2 proposals for what might be low-hanging fruit. The first is that communities, ministries of health need to define a essential medicines primary care package that every community should have access to. And that should include things like a basic medicine for hypertension, a basic, baby aspirin available. And then in addition to that, we should try to get the metric for better health care changed from number of specialists in country to some better quality indicator of access to primary care. So it would be access to primary care provider and the basic package of essential medicines. So those were our 2 low-hanging fruit that we propose.
Thank you very much. Table 7. How about we go to table 3 next?
We had a lot of really exciting conversation, but also a lot of convergence in ideas. And then when new ideas come up, everyone just kind of jumped in. So we had a really nice talk. Some of the major conversion ideas were really moving away from this this talk of individual focused interventions and responsibility, and really moving upstream and thinking about the most critical interventions as policy interventions, and social interventions that may be impactful. Another was really caring for people, patient-centered, people-centered care, as opposed as much similar to what you said, specialized, individuated care, including frontline health workers. So the first person you see is taking care of you as a person and all of the conditions you carry with you. Then also a really important thing we talked about was stop labeling. We need to stop ourselves today, stop labeling people as researchers or policymakers. Patty is a great example of that. Or people who study HIV or diabetes or NCDs in general, or infections or in general, and thinking about kind of complex problems and how we can work together. And 2 other big convergent ideas. I guess thinking about how we package messages, and thinking about probabilities and how we talk about our research in really productive ways is an important priority. And bringing those messages outside of the health sector and looking at these policy level interventions as health interventions, including like desegregation. So new ideas were really taking seriously the food and agricultural systems as fundamental health interventions. So also thinking about what foods are produced, so how much corn is overproduced and then put into high fructose corn syrup that's then put into high caloric foods that are given to low-income communities, for example. It's not just corporate responsibility, it is definitely is targeting those commercial determinants, but also thinking much deeper about historical subsidy programs that are fueling the overproduction of corn, or really thinking about these systemic inequalities that are producing these problems. And from that, really moving to, and so this is, at a fundamental part of thinking about solving diabetes problems. And so then thinking about planetary health as the most inclusive framework that we have right now, thinking about how all of this convergence happens and what's driving it. And then what are the possible outcomes of us as a planet, as one planet. And then also along that line, going back to basics and thinking about these population level interventions like chlorinating the water, structural, like we talked a lot about how elevating the minimum wage could make a really big impact on health outcomes, infection and non-infection. And then our actionable items were becoming more activists. Let's do this. Let's talk about our work in a more public way. We're all on Twitter, but are we writing in the New York Times? Are people reading for us? Are we blogging from our kitchens? I mean, AOC does it. Why can't we make diabetes sexy? Let's do it. Really being actionable and tackling also this corruption issue. Especially in the U.S., why are things not happening? Well, there's a lot of lobbyists controlling the message. We have a lot of evidence, but not a lot of political will. How do we tackle that? How do we deal with that? Where are our voices in the mainstream media? Where are our voices? And how can we build coalitions across sectors to really make this critical evidence that we've built actionable and actually pushing the change that we want to see?
Thank you, table 3. How about we go to the back of the room, which I think, is that table 6? That comes after 7 for some reason?
Okay. So it's interesting when you listen to all of the groups, because I think we all probably talk about similar things, and we may have sort of bucketed them in different areas. We probably spent the most time, I would guess, talking on what was not really discussed, what was missing. So I'll try not to duplicate too much of what's been said. But in terms of the theme where there was convergence, I think we agree, sort of the siloed and life cycle donor / funding interests, that they're sort of disease focused. I think also when a good example that was brought up was in terms of globally, at least from the United States perspective, you think about national security, and if you're thinking about diseases that render a country or an economy less stable, diabetes isn't really one of them, so that's another reason why it may not get as much attention. We talked about a few sort of low-hanging fruit areas, and I'm just going to say one that hadn't actually been mentioned, although started to with sort of the tweeting idea, and that is, but looking at it more from the individual perspective. So we talked about kind of cell phones, right? If you go everywhere, people have cell phones. In the middle of places where they don't have much else, they have cell phones. So no, we're not asking them to tweet or tweet to them, but sort of creating kind of shared communities around this, so you can empower the communities, involve them, and then you can also educate them perhaps through this. And then it's kind of the area that maybe, again, has been touched on a little bit, but that could be worked on, or that was missing, was really sort of like a cluster analysis of all these factors to really make a healthcare system development more efficient. So it requires the inputs that we've talked about, be they specific to a disease, be they social or commercial determinants, or other sort of shared inputs. And then it also requires the economists perhaps to do a cost analysis for whatever this integrated model is. And so you can do that so that you can understand all the services that are required and how the individual level needs are related to one another. And then from there, you'd have a strategy for using our limited resources and maybe any policy that may need to follow.
Thank you. How about we come to the front, to the table formerly known as 2? Doesn't seem to have a label now.
Thank you. So in this table, Bumi, the student who was planning to just come and listen, ended up having to kick off the discussion by reminding us how ignorant we are. She basically pointed out the issue of the knowledge gap, and we ended up having a convergence around the problem of not knowing who knows what and not knowing what we don't know. and also not asking the questions that allow us to be able to find answers to those questions. There's a challenge in terms of how best to access information about things we don't know. And we were reflecting again about what was being discussed today in terms of saying that, oh, there is this information. If we have it, it can go into the policy landscape. It can help influence the way we think, the way we do things. But people may not know where that information is. And at times, that information truly doesn't exist. And when it does not exist, then we can come up with research that helps us to produce that information. But just the fact that there is this knowledge gap that we haven't necessarily mapped out, and we don't really have clear ways of engaging with, and we only engage with that knowledge gap within our silos. But having to try and engage with the knowledge gap across silos becomes a challenge. We need to figure out how to do that. And that may broaden the borders of the sort of fields in which we ask questions, or from which we ask questions, and diversify that. But that is the way that we may be able to bridge the gaps that currently exist. Related to that, in terms of the life course, we also realized through her, reminded us that younger people have a different way of engaging with means of searching for information today compared to years ago. So we have to remember that, and we have to think about how to tap into the innovation, the technology that currently exists in terms of finding information, but also sharing information. And the example of Twitter is one example. But we have to also then think about the different stages of the life course in terms of how people engage with information and the means that they use when we think about addressing knowledge gap and sharing information. The next thing that I think was important that was addressed around the table was the issue of deficit versus asset. It's a lot of times we tend to focus on what we don't have, and we don't necessarily spend a lot of time thinking about what we have and mapping out what we have and leveraging what we already have. There's more rewards for coming up with new things, and you get patents for that. But we don't necessarily go back to say, actually, what is it that we have, and leverage that. It was, I found it really kind of mind-blowing yesterday when Rob was talking about how they decided to study normal people. And I was like, that's an idea there. So we need to do the same thing. We need to think about, before we rush off to say, okay, this is what we don't have, let's look at what we have. Let's put it together and see how we can maximize the use of that. And linked to that, it's the issue of trying to embrace the complexity that we have in our context, in the landscape. We were saying that in order to make convergence work, maybe one way of doing that is to look at the landscape and study the landscape and understand the context. If we were to kind of do a socio-ecologic profile of a community, and instead of thinking what would be the right mix, to achieve the convergence between ID and NCDs, we say within this particular socio-ecologic profile, this will be the mix. Within that socio-ecologic profile, that'll be the mix. And that way you tailor your approach to that particular socio-ecologic profile instead of having a standard package. What we've been doing for a long time is coming up with standard packages for everyone, but we were not necessarily tailoring it. It is a bit challenging because it asks for a dynamic approach to the way we plan services and we respond to needs in the population, but then our responses would be more relevant to those communities. Therefore, characterizing the syndemic of those communities become important in order for us to plan the services instead of just coming with a standard package of care. We've also raised the issue of language. I think one of the things that we could do right away is to start shifting the way we use language and use more inclusive language. because language can exclude people, and we end up doing a lot of othering. I think someone has already mentioned that. And so we need to try and avoid that. And in doing that, we also need to recognize that there is wealth of knowledge that will come from other people who look at the world differently, including community members. There's a wealth of knowledge that will come from people who are on the ground or the community members that we can learn from. And what we are used to is to coming up with our own questions and holding everything else constant so that we can find the answer. But in the real world, it becomes important to actually hear what the people themselves are saying. And it links to this idea of people-centeredness, but it also links to the idea of us sometimes overlooking windows of opportunity. If we are to sort of listen to other people, we may be able to identify those windows of opportunity. For example, if we're listening to policymakers, we may be able to find from them something that we haven't thought about as a window of opportunity. Likewise, there are unanticipated events that may affect the plans that we put in place. But because we may not know the context or we may not know what else is going on, we can miss those unanticipated events. And whilst we have to understand and figure out what possible missed opportunities we may experience, we also have to help other people think about their own missed opportunities. So within the ID community, you may have a lot of missed opportunities relating to NCDs, but then people who are also in the NCD community may have a lot of missed opportunities related to ID. So we have to think about missed opportunities across the board. And lastly, I think what we would really like to do, perhaps, or propose, is to do a review of examples that work, things that we know have been achieved already in terms of success. So there will be examples of successful readiness to change that may come from other fields that we may bring into health systems or at a structural level. And those examples of success, we may be able to leverage them to take this agenda forward. And it relates back to that idea of trying to understand what we already have and appreciating what we already have instead of just coming up with something completely new without the evidence base for it. But once we have identified the gaps, then we can come up with the relevant research pertaining to the things that we don't know. Thank you.
Thank you. How about we go to table 5?
Hi, I'm Emma Mendelson from EcoHealth. So our table, we talked a lot about communication. For us specifically, we talked about it in the context of mechanisms of the microbiome, but it applies more generally to communicating why convergence is important in tangible, mechanistic ways that can be accessed by a general audience. So as an example, how diets can contribute to health. And these are smaller steps that we can take to start to address these larger problems. One interesting thing that we talked about that I don't think has come up yet is how there are profit incentives that can contribute to NCD risk factors. And we were specifically talking about the fast food industry and the economic motivation to sell things that are not healthy to the general population. And that's something that we don't have as an issue in EIDs. Nobody's trying to market influenza. And the profit is on the side of curing those diseases. So it's an interesting distinction that is important to keep in mind in what is driving NCD risk factors. We also talked about just generally some major topics that haven't come up yet. A few infectious chronic linkages that I believe Jay will be talking about pretty soon, but also just the issues of mental health and mental illness is major. Pollution and toxicant exposures that can contribute to NCDs and at the same time make people more susceptible to EIDs. It's a large unknown, but it's probably a very important topic. Yeah, I think I'll leave it there. Well, we also talked a little bit just about the need for data sharing, which is maybe a low-hanging fruit, not entirely, but just understanding what the landscape is of data, specifically as we look forward into the future and projections and what informs those models and how we can improve those models and general work on distributing data within the community.
Thank you. And table 4.
Okay, so going last, I think, obviously a lot of things have been talked about, so I'll try to keep it to some things that sort of came up uniquely in our conversation. I think that in thinking about the things that every individual at our table thought they could do, I think one common theme was collaboration and the sort of connections that were made at this workshop in terms of bringing in ideas from, disciplines that are sort of a little bit outside of the areas that we work in. And so I think that's sort of one area of convergence in our conversation. But even more than that collaboration, sort of attempting to prevent the silos in the first place. So even, we talked about language, but in sort of naming things in ways that aren't creating these sort of artificial silos to begin with. And the organization of programs and teams and organizations themselves in ways that tend to silo those things. And then we also talked about person-centered care and the community, the importance of the community as far as healthcare, but also in terms of anti-corruption. We talked about improving regulatory pathways for therapeutics in the microbiome. A few issues there, but also around equity for access to that globally. And then identifying clusters of comorbidities using large data sources to then sort of take the next step and identify syndemics or some of the social underlying factors that could be creating those sort of clusters of comorbidities. Yeah.
Excellent. Thank you. Every table reported, right? I didn't miss a table. And you would say so and not just hide out, right? So we have some time to just kind of talk in an open-ended way. But I just thought first I would put out a call for anybody who kind of heard something, had an aha moment at your table that didn't show up in your tables, report back. Like anything you feel like you want to put into the room and also put on the record for the workshop proceedings. Any aha moments, bits of clarity? I think Jared has the mic.
Maybe it was just picking up on something that you mentioned, Emma, from your table, and to give it a name, a word that we maybe haven't mentioned, which is trade-offs, right? Because you're talking, and convergence comes with trade-offs, particularly in the context of when the drivers of what you're converging are not necessarily converging. And so that was just something that stuck out in my mind that is worth considering. And this is perhaps even more why we need that, to think in that systems approach, because there is no single, if we're doing anything I think that we think has no trade-off, we probably just don't know the system we're working in, because everything is interconnected in some way. So at least for the big things, what do we know about the ways in which they interact? So that point was very well taken. And in then thinking about how potential interventions, could an intervention potentially improve ID and make NCD worse, or vice versa? So this trade-offs are, I think, just something to. Yeah.
Anyone else with
a very specific interest of mine is to have food allergies recognized as a global health problem. The community still has a lot of pushback because the prevalence has increased so rapidly, and there's a whole generation, my generation, where food allergies barely existed. Food allergy families have a lot of problems accessing accommodations. For example, peanuts on airplanes. For somebody with a peanut allergy, it can be life-threatening, but there's still resistance from most airlines to allowing families to pre-board and themselves wipe down the seats and remove crumbs, because that's all it takes to set off an anaphylactic response. So I think recognition by this group that this is a global health problem would be helpful for advocacy.
Please.
I was just thinking, I know we almost keep forgetting it's a forum for microbial threats, right? Which is quite interesting. I would love to have, with this, if this was happening again, have different sectors represented. Because again, when we're thinking about upstream, we think about something was mentioned on our table that you mentioned, so thinking about, say, the opportunity to think about disasters as an opportunity to prevent. And so you gave the example of Haiti and how, you have cholera and all like negative, acute, both infectious and non-communicable disease outcomes that you could think about, well, what are the ways in which the planners can incorporate that coming out from that? But I think sometimes we sit here and we just, in as much as other sectors assume, oh yeah, the health people have got it, we also assume, yeah, planners are thinking about cholera. They're not. No, not by default anyway. So the more we can do to be more inclusive in these kinds of conversations and bringing together so that we have ownership of this agenda to think more holistically about health in the long term.
You were making, it occurred to me that I think this happens a lot in health spaces where we start to talk about, things outside of the health sector, where we're breaking the nothing about us without us rule. Because we talk a lot about how important the other sectors are and how, if these other sectors did these things, they would be health interventions, and we're framing their whole lives as if what they exist for is health. And also, making assumptions about going back to, are there assumptions, Rachel raised that in a more concrete way, but are there assumptions we're making that we shouldn't be making about other sectors? So tying that observation. Mm-hmm.
From the conversation, and that's resilience as a way of thinking about populations and individuals, what makes them resilient, not affected by diabetes or what have you. And I think that, what was I going to say? It's a very, wait.
When it comes back to you, let us know.
Okay, can I make one point?
Of course.
I guess mine is a question. It's about whether this agenda to kind of converge ID and NCD, if it's a threat to anyone or anything, and whether we should anticipate pushback, or we should think about the sort of unintended consequences of doing that. And maybe it links to the idea of trade-offs. But for example, I would think that if you were to focus more on health promotion or upstream factors, you might end up with a situation where people who benefit from the current model might end up losing, because then you might be closing the tab. So I'm just wondering if maybe there's a way to think about that and frame that in a way, or anticipate and think about it in a way that can be constructive in how we move forward with this agenda. It's a comment and a question, if anyone can answer.
I'd be interested in turning that question back, because I think it falls under the category of maybe issues that haven't come up yet. A little bit, there were some discussions about, the trade-offs that might happen in an individual service delivery model. But this idea that who's going to lose and how much power do they have to resist the change? And, is that something where you can work to mitigate that loss and make it more of a win-win, or a lose a little, or is it something where you really, and I think the idea of risk factors that are tied to profit incentives is already one example where there's an actor in that who will lose. One that comes up, I think, in the chronic disease conversation a lot is tobacco. So if you have a state-run tobacco industry, or just the tobacco industry is a large part of your economy. That is someone who will lose if there is good tobacco control. Are there others that people can think of that should be part of the conversation so that we're looking ahead to who you might need to talk to, who you might need to partner with, whose interests you might need to understand better?
I think this is way out, but I think we should look at what's happening with marijuana legalization and the changes. Again, there's a continuum. There's recreational and there's medicinal, and there is a convergence. There is a convergence in terms of thinking about mental health as prevention and recreational. It's not really recreational. I think it prevents NCDs and all kinds of other things. And I think it could be used as an example to look at stages of change, how quickly different states have integrated things, whether they've integrated into the healthcare, into the police. So I think if we take a fresh look at that. The other one is the microbiome, which I missed yesterday, but is a favorite of mine in terms of bridging health and treatment, research and care. Because it's it's an example where as soon as we learned about the microbiome, it was being used clinically for different diseases. That's highly unusual. It's highly unusual for there not to be a gap between the knowledge base and the integration. That happened with marijuana for different reasons. But I think microbiome really is a perfect example of what we find out about the microbiome, how it affects NCDs and infectious diseases.
Any other, so I see your hand, and then.
I did want to expand because on that comment about microbiome, because it's something we discussed some at our table, an issue I raised. Our speaker, Rob Knight, I think, yesterday, alluded to the issue of how the FDA regulates the microbiome. And that issue of rapidly moving from understanding to treatment is a critical issue that is tremendously influenced by what regulatory pathways are. So in the case of the treatment of C. diff, it happened before the FDA decided that there was something there to regulate, which isn't to say that FDA regulation is bad, because you could spread communicable diseases. And frankly, if something like that is easy enough to do without regulation, there's no incentive to invest the tens or hundreds of millions of dollars it takes in clinical trials for the broad spectrum of possible treatments and the broad spectrum of possible diseases to find out where it works. So to me, we're at a critical juncture there in trying to figure out how to get it right. I know the agency is. It's one of the issues I think that, I've seen it happen in stem cell therapy and gene therapy and antibody therapy and biosimilars, where you put the regulatory hurdle has a huge impact on what research gets done, what therapies get developed, how much they cost, and who has access to them. And it's going to be an important factor here.
Yeah, and I want to follow on a little bit on this idea of what various industries are going to do with this convergence. Because, if things go well and the whole planet decides to follow our guidance, our suggestions, then the livestock production industry will be making less money. The vaccine companies will be doing less, probably. I mean, it's from the farmer point of view, we're going to be focused more on supplements, nutrients, changes in diet and lifestyle, and there'll be lots of products out there that come from around that. And you think about some of the microbiome type supplements. But I guess what really will happen is intelligent, well-run companies will see a market niche that they should get into, and they'll either purchase those companies, buy them up, and get into that business and get rid of other units. That tends to be what happens. I don't know much about it, but I think that's what I see. And but there are real potential for big changes in the future. And if there's real concern, for instance, in Asia on obesity related to huge meat consumption projections into the future, that will have major implications for companies here in the States and in Europe, which are supplying that as well. So I think there's some interesting future issues down the pike as the public, in especially the rising middle-income countries, realize that it's no good just eating KFC. There are some health negatives to that. Anyway, interesting futures to think about.
Just to build upon that and thinking about industry, I think because we're talking about health and convergence of these diseases, we often focus on the health private industry. But, certainly in the sub-Saharan African context, if we look at where the rapidly growing cities are, where population is growing, and the environmental exposures, these cities are not being built by public policies, they've been built by private industry. So there is a whole separate disengagement with the development industry as actually an important industry for health. It's not just a pharmaceutical, it's not just the biotech industry. In what ways are we actually engaging? Because that's the reality of the urbanization model in a lot of these cities. So we engage with the policies, and that happens to some extent at the local government level. But a lot of the master planning and a lot of the ways the city is going up, and as a result, the kind of exposures as impact on both infectious and non-communicable diseases are being driven by industries that it's not even malevolent, it's just a disengagement with thinking about health. And I think we can do a lot more in working with that industry and thinking about this approach.
Just to continue with that theme a little bit more, Tolu, I love what you just said. And one of the ways to address that's only gets limited use is the health impact assessment. And so, of course, the World Bank is required to do that, and some of the other development banks and funding agencies do that. But that's only with their projects, of course. So, one action item, it's not exactly low-hanging fruit, but it's certainly feasible, is to really advocate for a health impact assessment or something like that when there are, major development decisions. And wherever that table is, or those tables are, that there's some discussion of that. And economic evaluation can be a part of that, but, there are other tools and methods. I just think it's a really important point.
I'd like to probe on this topic of what do they have to lose in connection to the bottleneck that came up so much earlier, which is the funding streams. So that just has come up a lot, whether it's government funding because it's earmarked or whether it's donor funding because it's disease specific. That, was high on the list of things that if that could change, it would make everything a lot easier. And that problem of siloed funding is one I hear in every sector I've ever worked in. So that's, from early childhood education to global health to rural health, everywhere. What do you think, what are the people who hold the money, what are they going to lose by changing that?
So if you're funding, if you have your money to fund whether it's HIV or cancer treatment or cardiovascular health, you may, as an organization, be more broadly interested in getting bang for a buck in improving public health. But what you have to report back is what's happening to HIV or cancer or whatever it is that is the metric that your organization is being judged by for its effectiveness.
Mm-hmm. Actually, we were talking about trade-offs, right? I will challenge that, saying that maybe we should start also investing on strengthening the capacity for collecting the information that is needed, and not necessarily you're going to lose metrics. there is another thing that probably sometimes funding agencies lose the sight of, okay, which is how complicated you make our lives in governments, asking for every single metric that they want, and every single agency will ask for a different metric, okay? Of course, I mean, if you know about mathematics, you may try to use your numbers on one side, on the other. But what happened is that several times that becomes at the bottom level, 10 or 40 different papers that they have to fill out in order to consolidate. So I think, and that's another pledge, I think if we're going to talk about convergence, okay, so convergence had to be at every single level, and we have to think strategically about those metrics. So we don't need to push providers or institutions, et cetera, to be collecting so many numbers. Let's try to be strategic on the numbers, and let's try to strengthen the capacities to collect that information that will be more reliable at the end. And you can have the metrics that you need, but the convergence should include that topic too.
I just wanted to add to this because as mostly a professor, I mean, I teach this, and this is a conversation that's been going on for decades and decades and decades about, really investing in systems, in investing in societies, or having these very metric-driven interventions. And we know that those are not the most effective, and we have the data to show that it keeps creating these cycles and perpetuating these inequalities in pretty deep ways. So we need to move beyond this idea that we have to have these very individuated outcomes that are disease specific if we're going to make change. And if we don't do that, it'll probably we'll just keep perpetuating the same inequalities and problems.
Any thoughts on why that message, despite it being a consistent message for decades, is not getting through? Just for the record, Emily said the power of funders. Yeah. Sorry.
Yeah,
Go
I
ahead.
was just going to agree that a lot of donors are motivated by a particular disease. That's just a reality. Let's do something about Alzheimer's. Let's do something about diabetes, and so that's what they want to see from the organization that they're giving their money to.
So let's do something about people.
I think there may be something more fundamental in public health about that as well. So, where did first public health data come from in London? It came from counting the number of dead people, essentially. Then moving on to cause-specific deaths. So, the information systems were originally kind of driven up just to count the number of deaths, the number of different causes of death. In a very simplistic way, and we still tend to think in that way because the metrics that we believe are more important, the health-related quality of life, are also actually far more difficult to measure, and even the good information systems are not set up to measure them.
So maybe a little bit tangentially, but related to metrics and indicators. I think sometimes the public health and the health, we are worse at the silos than, so just an anecdote. We've got a project looking at integrating human settlement and health policies and looking at the potential to use those data to look at the health impact of some of those human settlement interventions. But when we were co-creating the research with Department of Human Settlements and Department of Health, and the Public Health University Department, when we went with human settlements, the argument is around, pulling around thinking about the health impacts. They weren't like, but are we looking at infectious diseases or are we looking at non-communicable diseases? It was kind of, what are the kinds of adverse health outcomes that the work that we do and our exposures determine? And it happened to be a combination of both. When both in the Department of Health, in Government Department of Health, and the Public Health Department, it was much more, so do you want infectious disease indicators or non-communicable disease indicators? And I think that was just a really good anecdote of we're the ones that think we're pushing the frontiers of thinking about convergence, but it's not even on the radar for getting people who want to work intersectorally in health. So I think there's a lot we can learn as well from that kind of intersectoral collaboration.
It was a nice illustration of one of your tables, you know, that idea of listening more when you go into these spaces and being open to the idea that there might actually be ideas about how to measure health that come from non-health people because they are not stuck in the boxes that we've put ourselves in. And then, you know, not, in addition to measurement, other things. So it's a good, actionable. Yeah.
I think another of the factors that reinforces silos is the way that healthcare providers, as opposed to public health professionals, are trained. As a physician, it was certainly my experience years back, and many of the physicians I know, minimal training in public health, minimal understanding of or appreciation for what public health professionals do for community health, for epidemiology issues. And so the result is, and I know this is true, I have worked not much in the third world, but I know, for example, groups of oncologists in Africa who are working hard to have more oncology hospitals built in Africa. It's what you do when you're a healthcare provider. It's the way that world is organized. And I think at some educational level, I mean, there certainly are physicians who have a much more holistic view of health and of community health. And I think more physicians ought to have at least that appreciation and respect for what that's about.
Great. Well, I'm going to bring this to a close because we're to the end of our time and we want to have a little bit of a break to clear our heads before the next conversation. So thank you very much to all of you for this crowdsourcing of knowledge. Something that occurred to me in listening to all the tables is that it's easy to default to think about the convergence in terms of each side focusing on the thing that's working for the other and kind of leveraging those successes. But what occurred to me in this conversation is that there's also space for both sides to work, I'm oversimplifying the sides, but to work together to solve the things that aren't working for either. And I think that hasn't necessarily been the lens we've been using. It's kind of been buried, but it felt very clear to me. So that's where my answer to where do I see hope in the middle just became that if you recognize that you're experiencing the same challenges, you can be working towards solving the things that aren't working for either of you. So I just want everyone to give yourselves a round of applause because that was a very robust and intense experience. And then we're going to take just 15 minutes. Precisely 15 minutes. Come back fresh.